Good morning, colleagues. Welcome to the second in our UK Health Security Agency Presents webinar series. This series of webinars are intended to share how we, in partnership with you all, work to prevent, prepare for and respond to infectious diseases and environmental hazards to keep all of our communities safe. Today, I'm delighted to say that we have over 600 colleagues joining us, including many of you from local government, the NHS, Royal Colleges, charities, industry and other government departments. Thank you all very much for taking the time out of your busy schedules to be here with us today. And particularly huge thanks to you all for the work that you are doing to protect health. We couldn't do our work here in UKHSA without you. Today, we are going to explore our work to tackle antimicrobial resistance. Antimicrobial resistance threatens the effective prevention and treatment of an increasing number of infections, and it is associated with huge costs to society. As I'm sure you know, we rely on antibiotics and other antimicrobials to treat common but also rare infectious diseases, including chest infections, urinary tract infections, sexually transmitted infections, and the range of things that have an impact on people's health. However, these organisms that cause these infections can change and develop resistance to the treatments that we need. In fact, antimicrobial resistance is now an urgent global threat, and combating it requires a collaborative effort between healthcare professionals, scientists, and the public. Earlier this year, the government published a new 5-year action plan, and next week is World AMR Awareness Week, which some of you will already be involved with, and it provides a great opportunity to improve awareness and understanding of the big challenges of AMR. And it also provides an opportunity to encourage best practice in reducing and controlling AMR. So today at this webinar, we will be providing an overview of AMR, the risks to global health if we don't control it, and the work that UKHSA and our partners are doing to tackle it. You will hear from colleagues in UKHSA driving this program of work forward, including Professor Diane Ashiru-Oredope, Dr. Colin Brown, Dr. Julie Robotham, and Professor Mark Sutton. After the presentation, we will move on to a panel and with the opportunity for a question and answer session. And we will be joining also in the panel by the speakers and also by colleagues from the NHS who are on the front line working on antibiotic stewardship. We will be joined by Professor Philip Howard from NHS England North East and Yorkshire and Professor Matthew Inada Kim, who is the National Director for AMR. We will also have more UKHSA scientists in the panel and public health professionals at hand to answer your questions, including Dr. Joanna Bacon, Dr. Russell Hope, and Dr. Trish Mans. So the question and answer is now open, so please submit your questions and we will come to them at the end of the presentation. We have also asked from some pre-submitted questions and I will come to a selection of those before going into the open Q&A. Please also remember to vote the questions that you would like answered the most, because if we have lots of questions, I will go to those first. And finally, I can confirm that this webinar is recorded and the recording and the slides will be shared with you all. So it is my pleasure now to introduce Professor Diane Ashiru-Oredope, who will start the presentation for us. Thank you all.
Thank you very much, Isabel. Over the next 25 to 30 minutes, myself and my co-presenters will present an overview of antimicrobial resistance, the challenges that we have with it, both globally and nationally. We'll also share with you how UKHSA is prioritising tackling antimicrobial resistance, including our national data and examples of the interventions that we lead on. Antimicrobial resistance occurs when bacteria, viruses, fungi and parasites no longer respond to antimicrobial medicines. And the antimicrobial medicines that we're talking about include the antibiotics for bacteria, antivirals for viruses, antifungals for fungi, and antiparasitics for parasites. Antimicrobial resistance occurs naturally, but inappropriate and overuse of antimicrobials, including the 4 of them that I've highlighted already, as well as poor infection prevention and control, can accelerate this process. And we know that antibiotic resistance bacteria is less likely to respond to treatment, causing serious complications, including bloodstream infections, sepsis, and hospitalization. And we also know that people that have bacterial infection that is resistant to one or more antibiotics are more likely to die from the infection compared to those who have an antibiotic sensitive infection. This is why it's important that we continue to have good stewardship approaches to use of antimicrobials. Next slide, please. The influences on the development of antimicrobial resistance are highlighted already that it is a natural phenomenon, but their influences and development for AMR are multifactorial. And this system map here provides a visual representation of the various influences, and you can see that they're extensive and comes from all different pathways. And the map shows the interactions between them. So this helps us to understand the pathways that spread of infection and resistance could cause, and the increased mortality and morbidity, and then identifying some of the interventions that we can take to impact on these pathways. And examples of those interventions are stewardship programs, for example, behavior change approaches, and infection prevention and control measures. And you can see through the pathways there that the infections may take place between animals, the environment, and humans. And then we have there the high level interventions and the influences that how they act on these pathways, as I highlighted. And then there are 4 key outcomes. How do we reduce the burden of the disease? How do we conserve and steward the effectiveness of existing outcomes? How do we slow down the emergence and spread of antimicrobial resistance? And then how do we stimulate the development of new antimicrobials, diagnostics, and novel therapies? And so we'll be covering some of those further on. Next slide, please. AMR SOS was a term that's been used very recently, and that's because it's been identified that more than 39 people around the world could die from antibiotic-resistant infections over the next 25 years. Much of modern medicine, as we've already been highlighted, depends on us having reliable and effective antibiotics to prevent and treat infections that follow the infections. And without the effective antibiotics, even minor surgery and routine operations such as cesarean sections could become high-risk procedures. In 2021 and in 2019, we've had the global burden of antimicrobial resistance published within the Lancet. And I'll ask colleagues to go to the next slide now so I can share with you some of that data. In the very first global burden of bacterial antimicrobial resistance study, which was published in 2022, focused on data from up until 2019. And at that time, it showed the true scale of antimicrobial resistance globally for the first time. And it revealed that the global antimicrobial resistance related deaths were much higher than those for HIV or AIDS or malaria. And that this led to 1.2 million deaths, and then playing a role across 4.95 million deaths at that time, so this is 2019. Further analysis was done in 2021, and then that covered up until 2021 data, again, global data. And that showed that there'd been a slight drop in antimicrobial deaths attributable to antimicrobial resistance, dropping very slightly to 1.14 million from the 1.2 million we saw in 2019. This followed, obviously, the social distancing and other disease control measures we had during COVID. So researchers have highlighted that that decline is likely to be temporary. In addition, in the 2021, what we see, and that data, which is now analysed over 31 years, is that we've had reductions in AMR mortality for children under 5 years old. However, for those over the age of 5 years old, there's been increased in mortality, and this has been particularly stark in those in 70 years old and above, where the deaths has increased to over 80%, showing the importance of continued action. But also the reduction we've seen in deaths from the children under 5 years old shows the importance of widespread vaccination efforts, improved access to WASH, so that's water, sanitation and hygiene, infection prevention and control strategies, and how they proved highly effective in reducing the burden of resistant infections in under 5-year-olds. Next slide, please. Antimicrobial resistance is also been shown to threaten the United Nations Sustainable Development Goals. And this slide here shows examples of how this works. In terms of health and well-being, antimicrobial resistance will make it harder to treat common infections, leading to more deaths, disabilities, and prolonged illness. In terms of food security, AMR threatens our food security because it jeopardizes sustainable agriculture and livelihood of farmers. Poverty reduction, AMR would disproportionately affect those in underprivileged populations, pushing them further into poverty. And the World Bank highlighted that an additional 28 million people could be forced into extreme poverty by 2050. If we move on to the next slide. Antimicrobial resistance, from a national point of view, antimicrobial resistance is on our national risk register and is identified as a chronic risk. A chronic risk are those that can make acute risk even more likely and serious. So they give in the National Risk Register, example includes climate change, which can lead to increased frequency and severity of weather conditions. And in the context of antimicrobial resistance, it highlights the potential to exacerbate the risk of infectious diseases, for example, during a pandemic occurring in an environment of ineffective antibiotics, which could lead to higher deaths from secondary bacterial infections. Also in the National Risk Register in the 2020 version, it was estimated that antimicrobial resistance costs the NHS £95 million per year. Next slide, please. In addition to the general challenges we have with antimicrobial resistance, our data is showing us that there is disparities in the burden of resistant infections. So, for example, in the data we've published today in the SBAR report, and my colleague, Dr. Colin Brown, will talk a little bit more about that in his presentations. The rate of resistant bacteria is significantly higher in the most deprived compared to the least deprived populations, and this has increased since 2019. We're working to understand the modifiable risk factors and subsequently to enable us develop relevant interventions to be able to tackle this. I'm going to hand over now to Dr. Colin Brown, who will take us through a UKHSA role in tackling antimicrobial resistance and some of the National Action Plan activities. Over to you, Colin. Thank you.
Thank you very much, Diane. So, first off, I just wanted to highlight that antimicrobial resistance is one of UKHSA's key priorities. If you see the third bullet highlighted there, one of the key strategic aims over the next 3 years is for us to reduce the impact of infectious diseases, specifically including antimicrobial resistance. So it's a core part of UKHSA work, not just within the AMR and HAI division, but across the entire agency. Next slide, please. What we have is the current publication of the UK's 5-year National Action Plan. This is the second 5-year National Action Plan in a series of a 20-year overall strategy to confront antimicrobial resistance. It's owned by the UK government, including all 4 nations, and each individual organisation has got specific roles within that. Department of Health and Social Care provides overall coordination, and UKHSA has played a crucial role in the development and implementation of the plan. Specifically, we've coordinated the development of the UK-wide human health targets that all 4 nations have signed up to try and meet as key targets. We've led on key outcomes and commitments, and we want to drive and monitor the impact of public health interventions with a specific view as our role within human health surveillance for AMR. Next slide, please. This is just to highlight a variety of the areas of which UKHSA is active. So across the top, we have some of the 9 key pillars of what is being done under the action plan, and I won't go into all of them here, but as you can see in red, these are where UKHSA have specific deliverables, so across infection prevention and control, public engagement, surveillance, antimicrobial stewardship, workforce development, innovation and influence, information for action, addressing health inequalities and global action. We have key activities that exist across the board. And we were working very closely with partners both in the 4 nations, in the allied agencies that cover animal and environmental health, and with our public health counterparts in the 4 nations. Next slide, please. This is just to highlight that within the SBAR report just published, we address a lot of the issues that are being identified as core components of the NAP. We have chapters on antimicrobial resistance and the state of current knowledge within the UK, antimicrobial consumption, and in particular within both of those, the progress that we've made towards the previous targets within the last 5-year National Action Plan. We have a point prevalence survey, results for the latest healthcare associated infection and antimicrobial usage point prevalence survey that we conducted last year. We highlight all of our antimicrobial stewardship activities and all the work done for professional and public education. We give an overview of the disparate and very wide-ranging research activities that exist across the organisation, and then we have updates from each member organisation of the SBAR Oversight Group, which includes NHS and key colleagues, and then there is some feedback, lay summary, and in particular a piece from NHS England on their improvement and assurance schemes. Next slide, please. Some of the key highlights are that antibiotic-resistant bloodstream infections, so a core marker of infections we are most concerned about, those that affect the bloodstream, likely with the highest mortality, that we have got increasing amounts, not by great increases, but nonetheless an increase in bloodstream infections that were antibiotic resistant in 2023. So we now have 21 out of 100, so just over 1 in 5. Of bloodstream infections that have a resistant profile, making it more difficult to treat, more difficult to get the first line antibiotics right, and potentially more side effects for some of the antibiotics that are used. Next slide, please. When we look at the total antibiotic consumption, we have 17.6 defined daily doses per 1,000 inhabitants in England, which is a measure of how we report on antimicrobial consumption, and this represents an increase of 2.4% compared with antibiotic consumption in 2022. It is still below the pre-pandemic 2019 level by about 2%, but we are nonetheless seeing trends that had been interrupted by the COVID-19 pandemic now revert to those that we're seeing with small rises in the trajectory that was seen pre-2019. Next slide, please. If we look at where those antibiotics are prescribed, 80% are prescribed in primary care, and then secondary care deals with a large portion of the remainder, and there have been notable increases within secondary care in accident emergencies and in other specialty services, and it's in the secondary care format that the most broad spectrum antibiotics that we like to reserve use of are most prescribed. Next slide, please. This is just to highlight that we have open access to all of this data that you can get through local AMR indicators on our fingertips platform. We produce data across 6 domains, those that support NHS England initiatives, antimicrobial resistance, antibiotic prescribing, healthcare associated infections, IPC measures, and antimicrobial stewardship. And I would very much welcome anyone who's interested in looking at their own local data within a national context to access this on fingertips, which is freely available. Next slide, please. So now I'm going to hand over to my colleague, Julie Robotham, who is our head of modelling, to take us through some specific uses of how we use data.
Thank you very much, Colin. As Colin just mentioned, so UKHSA collect and hold a wide variety of data, and there's real emphasis on making best use of these data to generate insights for public health action. And we use models as powerful tools to really help us do this. Firstly, they can help us simulate the potential impact of different intervention strategies and changes to policy and practice before they are implemented in reality. This is incredibly valuable as it enables us to assess both the effectiveness and cost effectiveness of many different intervention strategies, exploring their impact across different populations, across settings and scenarios. So this really helps us to explore a wide variety of solutions to the complex problem of AMR. A classic difficulty in evaluating the impact of public health interventions is understanding what would have happened if we had done things differently or if we hadn't intervened. And again, this is another area where modelling can really help us. And finally, it can help us unpick and understand the data and trends that we are seeing to really help us uncover those underlying mechanisms in the epidemiology. Next slide, please. So we use modelling and health economics techniques to really help us make optimal use of our surveillance data. First of all, we estimate the burden, both in terms of health and cost. So for example, how much does antimicrobial resistance cost the NHS? As I just mentioned, helping us to understand the drivers and the underlying epidemiology. And together, these things can help us try to predict the future and understand what the AMR trajectories into the future might look like. All of these three things collectively are really crucial to help us estimate what the justified level of investment in control is. If we understand how much AMR costs now and potentially in the future, it helps us understand how much we should invest into its prevention. Also, really understanding those drivers and burden helps us design better surveillance strategies and design better interventions, and also really robustly evaluate interventions to make sure that we have evidence-based decision making. And collectively, all of this should really lead to improved resource allocation and more rational decision making, making best use of our budgets, and improved public health in terms of reducing those resistant infections and the consequences of them. And really importantly, all of this collectively can really highlight what we don't know, where we need more information and data, and the future research directions to make sure we are making rational and cost-effective decisions for the control of AMR. Next slide, please. I'm now going to talk through a number of examples of interventions that UKHSA leads. The first of these being eBug. eBug is a UKHSA-led international health education campaign for children and young people, but aimed at educators. It was launched in 2009, partnering with various countries across the world with the aim of reaching every child and young person with messaging on infection prevention and control and antimicrobial stewardship to really try and promote behaviour change in the antimicrobial users and prescribers of the future. eBug offers fun and interactive educational materials which are freely available and take children on a learning journey throughout their time at school. Topics include microorganisms, prevention, spread and treatment of infections, with lessons being linked to existing national curriculum content. There is also teacher training available to really support the educators. Next slide, please. The next example is the Target Toolkit. So this was developed by UKHSA and is hosted on the Royal College of General Practitioners website. And Target promotes a whole practice approach to antimicrobial stewardship. So it's designed to be used by primary care teams, community pharmacies, and through to care homes. And it contains a wealth of information and resources on the best practice approaches to managing those common infections and optimizing antimicrobial use in primary care, which we've just heard is where the majority of use is seen. So the toolkit is really intended to support clinicians in implementing a cycle of antimicrobial stewardship to try and protect the effectiveness of antibiotics for the future, optimize diagnosis and management of these very common infections, and promote shared decision making with the prescribers and users. All of this should enable much more evidence-based, systematic and continuous management of these common infections. Next slide, please. Finally is the Antibiotic Guardian campaign. So this is a behaviour change initiative designed to promote responsible use of antibiotics and really combat resistance through this. So this was launched in 2014, and the campaign encourages individuals, healthcare professionals and whole organisations across both human and animal health to make pledges for specific actions that will help reduce unnecessary antibiotic use. For example, avoiding antibiotics for viral infections. Since its inception, Antibiotic Guardian has inspired over 200,000 pledges from more than 150 countries worldwide. By increasing awareness and encouraging really practical actions, the campaign is intended to empower communities to join the fight against antibiotic resistance and protect these medicines for the future. Next slide, please. UKHSA are involved in a wide variety of collaborative research, partnering with academic institutes and other public health bodies, both nationally and internationally. A great example of these are the Health Protection Research Units. These are National Institute for Health Research funded partnerships between universities and UKHSA. They form multidisciplinary centres of excellence for conducting translational research. And the emphasis really is on the translational nature of this research, intended to promote really demonstrable impacts for both public health policy and practice. And across the 10 years that the AMR HPRUs or Health Protection Research Units have been ongoing, there's a wide variety of examples of this translational research really informing both policy and practice. A good example of this is in the design of a very new and novel Sentinel-based surveillance system for C. difficile across English hospitals. Next slide, please. There are currently two health protection research units in the topic area of healthcare associated infections and antimicrobial resistance. These are in collaboration with Imperial College London and with the University of Oxford. These two health protection research units each have within them 4 main research themes, which are complementary to one another. And across the whole scope of those, there are a wide variety of research projects sitting underneath them across disciplines and across topic areas, with many UKHSA colleagues being involved across those many different projects. And as has been mentioned, many are outlined in the SBauer report each year and the impact coming out of those. Next slide, please. Now I'd like to pass over to Professor Mark Sutton, who's our scientific lead for healthcare biotechnology, to describe the science work at Porton Down. Thank you.
Thank you, Julie. Many thanks for that. So I'm going to introduce some of the work carried out by teams at UKHSA Porton Down, very much in the translational research space and very much under the innovation and influence theme within the National Action Plan. So we as a public health agency are concerned about the future pipeline of antimicrobials, and also the loss of key skills and expertise in that space. So something that's of significant concern. So we work very closely with academia, small, medium enterprises and pharma industry to try and address that shortfall. And we do that in a number of ways. So the Open Innovation in AMR platform is one of our processes. This is a way of leveraging skills and expertise within UKHSA to support innovators in that early stage of drug discovery. And we were delighted that this was cited as a case study within the National Action Plan in terms of supporting innovation, and also that we were selected by the PACE Consortium to work with them as delivery partners around their recent therapeutics funding call. So we are working to support their grant awardees. So these are some of the most innovative companies worldwide, bringing new antimicrobials through to the market. And a similar theme underpins our discovery partnerships. This is work led by my colleague Joanna Bacon, who's on the panel today, and again takes a similar constructive partnership approach to working with industry, such as the work that Joanna did in looking at potentiators of drugs for tuberculosis. We're very interested in the non-traditional therapeutic space. So at the moment, we are trying to develop an integrated pathway to support use of bacteriophage in the UK, working with other public sector bodies, and really trying to bring phage into use for compassionate use for clinicians in the UK. Could I have the next slide, please? Thank you. Very similar themes in the vaccine and AMR space. Really, Porton has a history of almost bench to bedside support for vaccine studies, including studies that will hopefully reduce the use of antibiotics in the future. A lot of this work is founded on unique expertise within the teams here. So my colleague Stephen Taylor has developed a specialty around functional immune assays, and that work is really used now to underpin a wide range of vaccine studies worldwide. We also work in antibody therapy, so we have a phase 2 clinical trial led by my colleague Michael Maynard-Smith, looking at preventing recurrent Clostridium difficile infections. And all of this work is again underpinned by expertise in fermentation in the UK. Can I have the final slide, please? So the intervention space also looks at diagnostics and infection prevention and control. So the cartoon here shows a test that was developed or co-developed in my group to support rapid antibiotic susceptibility testing with colleagues at the University of Southampton. And this comes back to Colin was saying earlier about improving the therapeutic use for bacteremias. So the company IFAS Diagnostics are about to head into clinical trials for bacteremia rapid susceptibility tests in the UK. And there's also lots of lessons to be learned from the COVID pandemic. So we have a diagnostic accelerator that supports evaluation of rapid tests. And the final area just to highlight is infection prevention and control. So again, this is part of our Open Innovation platform, and this enabled Ginny Moore to build a modular hospital ward facility, which is used for applied transmission studies and to evaluate infection prevention and control measures across a range of applications. And with that, I'll pass back to Isabel to introduce the Q&A. Thank you.
Thank you very much, Mark, and thank you very much to all of our fantastic speakers. What a great presentation. And we've got lots of engagement in the chat, so thank you very much to everyone who's already submitted questions. I will come back to those. Please don't forget to like those that you are more interested on, because I'll prioritize those. But I'm going to start, first of all, by bringing in our NHS colleagues. And Matt Inadakim, I just wonder if I could start by asking you a question, or in fact, a double question. We had a question submitted prior to the webinar, and it was about what is the biggest myth about antimicrobial resistance that you would like to bust. And once you've maybe given us your thoughts about that, I wanted to come back to you and ask you about the question that's been most liked in the chat. because our presenters highlighted the importance of system working and system leadership, and there is a lot of interest in the role that integrated care boards can play also as part of their contracting with independent providers, and whether they should be applying or requesting the same level of audit and assurance that is applied in the NHS. So I just wonder if you might want to comment on myths in this area and what you would like to bust, but also the role of ICBs. Over to you, Matt.
Oh, thank you, Isabel, and thank you all. Really great presentations to set the scene, by the way, all fantastic. This is a really critical area, and I guess my answers to those questions are actually quite joined up. I think the myth with antimicrobial resistance is that it's an isolated phenomenon and is not linked with anything else, an existential crisis for one reason or another. But it pertains to the whole of optimal clinical care and for both patients and the way clinicians and services deliver that care and the way allied health professionals support it. So these are not in isolation at all. And it's only, I think, through the better join up of all the elements of Diane's diagram earlier of prevention, the One Health type approach, diagnostic tests, setting specific pathways, but also more holistic overall pathways that we're going to achieve it. And we need to understand this in terms of leadership and collaboration across the system if we're going to make any inroads. And that goes to arm's length bodies as well as, you know, national arm's length bodies like UKHSA and NHS England, Department of Health, as well as on a local level, and for patients as well. Patients and frontline clinicians understand this really, really well. You go from a position of wellness potentially, or living with your chronic diseases, down a path of prevention. Nearly everyone becomes ill at one form or another with an infection of one form or another, and they're passed through this process of trying to navigate the channels to get access to healthcare advice or indeed healthcare assessment in community settings. And that is really hard in some parts of this country still. And again, Diane touched on the issues of deprivation, which make this incredibly challenging, both in terms of direct access, but also in terms of empowerment and education for potentially quite vulnerable groups. And then as you pass through and navigate your way through the pathway based on your level of acuity and sickness, you either encounter community services or you are passed on to the hospital. The same pathways exist for all. And the opportunity is not only delivering optimal care at that point, and that's where AMR issues really come to the fore in clinical practice, but then also the data supporting that, decision support, diagnostic tests, which are so important and so, you know, need of development over time. And then the cycle continues with secondary prevention opportunities and then passing the patient on through the pathway. So the myth for me is really simple. It's the lack of, or it's the fact that we view this often with a very, very narrow focus. We need to take off the blinkers and see the whole picture.
Thank you, Matt. So that's a really good reflection. So, of course, this is not just a human health issue, but it is a One Health issue. And I just wonder if, you know, maybe we can consider also a little bit how the human health agenda interacts with a One Health, both the sort of animal and plant health agendas in reducing the importance of reducing antimicrobial use, including antimicrobial use in food production. And I wonder, Russell from UKHSA, whether you might want to comment on this.
Certainly, Isabel, thank you. So we love to categorize infections and put things in boxes. So we'll talk about infections in terms of community onset infections or hospital onset infections. But as was demonstrated beautifully by that very complex diagram that Diane showed at the beginning of her talk, the microorganisms don't like to stay in these boxes that we try and put them in, and so you get all these different interactions between the different settings. And because of that complex picture, we have a program which includes interaction from organizations from all these different settings, and it's not enough just to reduce, say, antibiotic usage in one of these settings. You need to do it across the board. So from a surveillance point of view, we track antibiotic resistance and usage across the different sectors, and we regularly produce a One Health report where you can see all this information. And a great example of a One Health program is reduction of antimicrobial usage, where you can see that if you look at data from 2014 to 2019, for example, in the most recent One Health report that was published last year, you can see an 18% reduction in the human health antibiotic usage, and in the food producing animals, a 52% reduction. And all of this will help reduce that burden across the different sectors. So it's not just about surveillance and interventions. There's also a One Health approach to research and development of our capabilities and technology. And a great example of this recently is the cross-government pathogen surveillance in agriculture, food and environment PathSafe program. And this program was looking at piloting national surveillance using the latest DNA sequencing technology and environmental sampling to improve the detection and tracking of foodborne human pathogens and associated AMR throughout the whole agri-food system from farm to fork. So there is a lot of activity trying to piece together the infrastructure and methods we need to track these AMR pathogens, and under that, the actual underlying AMR mechanisms across One Health. And there's still a lot of work to do, but it's ever improving.
Thank you very much, Russell. So another key part of the system here and key part of the response is the work of local government partners. And we've got a lot of interest in the chat about a question about what is the role of local authority public health teams in tackling AMR. I wanted to invite Trish Mans, who is Deputy Director for Health Protection in the Southeast region. And I just wondered, Trish, if you might want to comment on how public health teams in local authorities can support the AMR agenda, and what resources are available to help also local partners in this fight against AMR. Thanks.
Thanks, Isabel, and hi, everyone. It's really interesting presentations and great questions in the chat. So I guess, first of all, in terms of local authority public health role, we can't do this without you. And I think it's really important to recognise that local authority public health teams are uniquely placed in their systems as system leaders in their role on integrated care boards, their connections to all of the services commissioned and provided in local authorities, adult social care, education, etc., but also their links with environmental health officers and their key role in prevention of foodborne infections, as well as links and leadership across to UKHSA teams, ICBs, NHS England. So there's a really strong leadership role within local authority public health, and that puts those teams in a really great position. But also, really importantly, in local authority teams, they know their communities and they know where their inequalities are, and they know what works in those communities and what doesn't. So I think really core role and really critical role. And I know that there's a huge amount of work already being done in local authority teams in partnership to work on the AMR agenda. So I think in terms of what sort of things we're talking about here, I think there's a couple of areas in focusing on the core. So we already deliver through our core business a huge amount of work on AMR in robust and timely response to infectious diseases and outbreaks, and supporting environmental health teams in working through health protection fora and health and wellbeing boards, as well as work to support particular settings. So there's already a huge amount of work done, and in particular across the promotion of vaccinations, identifying high-risk vulnerable communities for focused vaccination efforts, etc. It's a huge amount of work already done, and let's not forget the important role of IPC capacity, both in ICBs and in local authorities, in supporting that agenda. So focus on the core and optimise the core, and sometimes looking at it from an AMR lens, for instance, in commissioning across sexual health services, can help to optimise those opportunities for interventions. And then also thinking about innovation, utilising some of the resources, working with particular settings. There's some really great, really simple stuff around hydration in care settings that can have a huge impact. Focusing on the basics, hand washing and vaccination remain some of the key ways to prevent antimicrobial resistance. So focus on amplifying those methods, both in settings, but also to the broader public, and utilising those unique skills that exist within local authority public health around knowledge of communities and knowledge of what works. And I think the final thing I'd say is there is a lot of great practice happening already out there in the system. Link in with UKHSA regional teams who can support you in identifying best practice, sharing that across the system, and ensuring we're all working together and doing once well across in our communities.
Thank you. Thanks, Trish. And as you said, we can't do this without the work of our partners in local government, in the NHS, in other government departments. You mentioned innovation. You mentioned innovation in how we can work with social care. Clearly, this is a big challenge, and we need. We've already mentioned innovation in terms of diagnostics and therapeutics. Innovation in models of care, innovation in how we engage patients and communities, and also innovation in how we work across the system. I wanted to invite Professor Philip Howard from the NHS, who's regional antimicrobial stewardship lead in the northeastern Yorkshire and the Humber, to just maybe reflect a little bit more in the area of innovation and what we are doing at the moment in terms of addressing the challenge of there being no new effective antibiotics. Thanks.
Yeah, thanks so much. Really good question. If we reflect before what Diane showed on one of her slides, that in 2021 there was over 1 million deaths directly attributable to drug-resistant infections. But what it didn't show that was in the UK there was 7,500 deaths from infections that we didn't really have any options for treating. So we're actually doing an awful lot within the UK at the moment. So antibiotics are a bit like fire extinguishers, if you think, from sort of modern medicines. We want them, but we don't really want to use them. And unfortunately, this isn't a very good business model for selling medicines in the conventional manner. So many of the pharmaceutical companies that were in the world of developing antimicrobials left the market, and so we've seen this dwindling off. It costs about $5 billion to get an antibiotic to market, and most of the companies probably only make their last any profit in the last year of when the drug's on patent. And there are a couple of approaches to overcome this, which we've been very much supporting within the UK. The first one is what we call a push model. This is whereby you can invest money to fund drug discovery teams to find and develop new antibiotics. UK set up the Global Antimicrobial Resistance Fund, GAMRIF, and it funds organisations like CARB-X, GARD-P, who assess and fund teams doing research. And certainly we've seen a number of new antibiotics which are now in clinical trials and hopefully will be coming on the market sometime soon. But companies still need to sell the drugs even when they get new ones coming to market. And we've certainly seen examples where some of these become bankrupt, such as a Qiagen who brought a new aminoglycoside, plasmamycin, to market. So the other approach that the UK really is probably the world leader on is within what are called pull models. And what we've done is we've developed something which is a subscription model. So a bit like you pay a subscription to your gym membership or for Netflix, if we're allowed to use brands, then you actually, whether you actually go to the gym or you watch films, you still pay for the service. And what we have ended up doing is coming up with a pilot in 2 antimicrobials. We had some help from the National Institute of Clinical Excellence to work out the value of these antimicrobials. And so we pay these 2 companies up to £10 million per year, irrespective of the volumes we use. And this is really based upon the UK's fair share of the global market. And we have really strict governance around the stewardship of these to make sure they're used appropriate. We're now actually just at the point where we've been working with partners from around the world, including the pharmaceutical industry, on a new model that can easily be adopted and adapted by other countries. And we're currently evaluating some of the newer antibiotics that come on the market and playing catch up on some of the older ones, which we need for what the WHO has called the critical priority pathogens. So these are the ones where there are very few options available. We've been really lucky. We've secured funding for 16 years, and we probably plan to run the funding cycle on an annual basis. And we're really looking at expanding it beyond antibacterials, possibly to antifungals, because got challenges there, maybe even diagnostics, and some of the things like bacteriophages, which Mark was talking about earlier. And to make sure we're giving the fair amount to the companies coming here, that the contracts will be up to almost £20 million a year for the really most valuable antibiotics for treating some of these infections. And certainly around the world, the UK has been seen as world leading in this area. So hopefully we'll have plenty more antibiotics coming through. Thank you.
Thank you very much. That's really, really interesting. So I've been looking at the chat, which is very interesting, and there were a number of questions on the EBAG program, and thank you to Julie for trying to answer those in the chat. But Julie, I was wondering if I could come back to you or to Diane in case you wanted to add a little bit more about the program, the take up, how it, what it's achieving, and maybe reflect on any contribution that our partners might be able to make to promote this program further. Thanks.
Can I let you pick up on that one, Diane?
No worries. So I think the eBug program has been available for several years now and in multiple languages. I think one of the questions was how do we ensure that schools are using the resources and not local authorities only. The eBug team manage the eBug program, and there's a primary care and interventions unit, and they do track that, and they have several projects as well as train the trainer approaches for teachers, which help ensure that the eBug tool is getting to schools. We also have the Antibiotic Guardian Schools Ambassadors program, which again is using the eBug resources directly for schools. Within the National Action Plan, there is a specific commitment around educating school children. So a lot of this will also be picked up through that over the coming years. But the eBug tool continues to be extensively used, and they track that through their the Google Analytics and a range of ways. And those are actually reported in the SBAR reports. So I encourage colleagues to look in the professional education and public engagement chapter in the SBAR report.
Thank you very much. Thank you, Diane. So I just wonder if you might be able to stay on with me for a second and maybe comment a little bit on the role of pharmacies on the Pharmacy First program. Some colleagues were interested in knowing whether we are capturing antibiotic prescription and consumption data from that program, but also those changes in primary care and the sort of increased pressures that we've seen in primary care, how this might affect our efforts to tackle AMR. Thanks.
Thank you. I'll start off, and I'm really going to encourage that Philip also contributes to this, as he's based within NHS England. So what we know, so just to assure colleagues, is that through the Pharmacy First programme, evaluation is being undertaken both within NHS England to ensure that it is effectively delivered, and also particularly to mitigate against any risks of its impact on antimicrobial resistance. Pharmacists have gone through a journey formally over several years in the community pharmacists, community pharmacy teams actually, around antimicrobial stewardship, and that journey started more than 5 years ago through the Pharmacy Quality Scheme, where there have been several training on antimicrobial stewardship, as well as making sure, for example, that all pharmacists, pharmacy technicians, including delivery drivers, have chosen a pledge to become antibiotic guardians. So there's been a journey that they've been going on before getting to this space. Obviously, the Pharmacy First is about increasing access to care around a range of minor ailments, and that has been in place, and pharmacists have been doing that for several years and are well educated, as well as able to do that. I know there are several concerns around antibiotic use. We're not seeing that from the data we have so far, and also to say that to make sure that the Pharmacy First programme is fully evaluated, NIHR, so the National Institute for Health and Social Care Research, commissioned a formal evaluation, which is being led by London School of Hygiene and Tropical Medicine, University of Nottingham, Manchester, as well as UKHSA, again thinking around the unintended consequences, making sure that we mitigate around any unintended consequences and this full evaluation. Significant processes are in place and clear algorithms are in place for pharmacists and pharmacy teams to follow if a patient turns up with an infection. I don't know if Philip, you wanted to add anything else from NHS England's point of view.
Yeah, thanks for that comprehensive overview, Diane. Yeah, so one of the real elements of Pharmacy First is around improving patient access, so we can get their infections assessed at an earlier level, and then where appropriate, give them advice and treatment, but only ever using antibiotics as a last resort. And with some of the early data that we have seen out, where we've been trying to recommend non-antibiotic alternatives, such as local anaesthetic ear drops for earache in children particularly, we've seen those being used at really high levels. The same impetigo again in children. We're seeing lots of local antiseptic creams being used in terms of antibiotics. And so what this will end up doing is allowing us to sort of follow the guidance that's being pulled together by NICE and actually using these non-antibiotic alternatives, and hopefully not drive some of the resistance on there. One of the really important things is that we've got here is pharmacy just won't be dealing with all of those patients. They will be that triage. So when patients need to go and see urgent emergency care, they will be directed into those fairly quickly, or if they need to go and see their general practitioner. And I think as we learn from what's happening within Pharmacy First, and certainly Scotland have been running this for very many years quite successfully, you may well see it expand. And ultimately, we want to provide safer and effective care for all of our patients, but at the same time, make our existing antibiotics last as long as possible.
So, Philip, you've given me a perfect segue into what I think will be our last question. So you've talked about safer care while preserving antibiotics. One of our last questions that's just come up relates to sepsis treatment, sepsis pathways. And Matt, you and I met for the first time in the context of sepsis work in the NHS, and so I know you've done a lot of work in this area, and I just wonder if you might want to comment about, in effect, how do we progress with the important work to improve outcomes for sepsis while making sure that we continue to have prudent and effective use of antibiotics. Thank you.
No problem. Yeah, it was really good to see you again as well. I mean, I think we are in danger of being swung by the pendulum of politics and populist views with regards to sepsis and, to an extent, AMR. And it swings and roundabouts. One year or one day, we're suddenly all into sepsis. And then 3 hours later, it's the AMR cascade that's causing all concerns or prevention. And what we don't do is have a balanced view enough. We sit in our silos. We criticize teams that overuse antibiotics, and we criticize the same team if they miss a case of sepsis. So the only way we're really going to move forward is by having a proper collaborative view on this, and understanding that we are all sides of the same coin, that we need to be pulling together towards a forward trajectory that improves the outcomes for patients with infections, all patients, and that is our goal. And within that goal, you have elements of what we need to do with an AMR, what we need to do within sepsis, infection prevention, control, diagnostic testing, communication, training, education, policy, communication. There are so many elements just within the human field that are absolutely interlinked, and yet we don't join together to actually have those conversations or have them as part of the same programs. We will never get anywhere without joining forces.
So that is an absolute perfect way of ending what's been a fascinating session. So I think our speakers have demonstrated that this is an enormous challenge and that we can only address it by joining forces, as Matt said, and working together. But there are really exciting developments, really great innovation in this space. So I very much look forward to seeing what we achieve working in partnership across organizations and across sectors. And thank you again very much to all of our speakers. As I said before, this will be recorded, so you will be able to access it online, including the slides. Thank you very much and have a good rest of the day.